Good morning and thank you for joining us. My name is Karen Curtis and I am a member of the Provider Outreach and Education team here at WPS. With me today is my friend and coworker, Mary Mugo. If you've been in the mental health program for a while, I am sure that you know Mary very well. She's done a lot of education on mental health. Um, she's going to be helping me out today by watching the chat for questions or issues that you may have. She's going to provide some additional information and links with needed. And I've also told her that if she wants to jump in and provide you guys with some additional information, I would love for her to, to do that. So you may be hearing from her throughout the webinar. Now, at the beginning of this year, Mary and I began holding webinars on the topic of Part B mental health. Last month, we started holding webinars on the top rejections and denials for different mental health specialties. Today, we are going to cover data for clinical social workers. I'll start out by describing the differences between a rejection and a denial. I'll tell you what the most common are for clinical social workers. Then we're going to cover how to fix or avoid these errors, as well as some resources of where you can find help. Time permitting, I'm going to respond to presentation-related questions, but I do want to let you know that claim-specific questions must be handled by customer service. Staff in that department has access to claim history, and they can answer your questions based on how your claim processed. You know, that's something that Mary and I can't see. Okay, so let's get started with rejections versus denials. Now, a Medicare remittance advice, sometimes referred to as an RA, is a notice that is sent by the Medicare Administrative Contractors, or MACs. This goes out to healthcare providers and explains claims rejections or the adjudication of claims. It includes payment information, adjustments, it'll give you the denials, rejections, all of that processing information. Now, the remittance advice includes codes that explain why a claim rejected or denied or even partially paid. You'll hear these referred to as claim adjustment reason codes, or CARCs, and remittance advice remark codes, or RARCs. The CARC explains why the payment was adjusted, and the RARC provides additional details or instructions. The RA may also list deductibles, co-payment, reductions, all of that information. Now, most providers receive an electronic remittance advice, and we only have a few that still receive the standard paper remittance advice. Those are usually for small providers. So providers can use self-service tools to access additional claim information, including a helpful reason remark code lookup feature that's on our website. Here you can take the CARC or the RARC code that you found on the remittance advice, and you can get a description of what those codes mean. Other tools include our secure net access portal and the interactive voice response, or IVR system. This can also provide you with additional information on how your claim process. Now, I have embedded links to all of these tools to use in your handout. Now, it is important to know the difference between a rejection and a denial. A lot of times these codes get used interchangeably. I know I'm guilty of doing it, but they really are different. A rejected claim is also referred to as an unprocessable claim. It's not adjudicated. It's returned on what we refer to front-end edits. Now, the reason we return an unprocessable claim is because something is invalid, it's illogical, and often because something that's required is missing or it's incorrect. Because a rejected claim is not adjudicated, there is no appeal rights. Now, you can easily identify a rejected claim on a remit when you see remark code MA130, and that goes along with the group code CO16. Rejections are done by the system and they are not the result of a claim being reviewed by internal staff. The provider must fix and resubmit the claim. The patient cannot be held liable for payment because the rejection is due to an error that needs to be corrected before Medicare can consider payment. So hopefully that makes sense. We don't want to hold the beneficiary responsible for something that could be an error. Now, a denied claim is adjudicated. Now, Medicare denies claims for a number of reasons. This can include statutory requirements, which means that there is guidance that can be found in Section 1861 of the Social Security Act that states that Medicare cannot pay for the service. Services must be medically reasonable and necessary is a term that you hear often in Medicare. Most of the time, you're going to find that there is a local or a national policy that's going to outline what would be considered medically necessary. There are also frequency limitations on some services, especially preventive services. Now, for example, the initial preventative physical exam, it's a once in a lifetime service and it has to be billed within the first 12 months of a patient's Part B coverage. So you can run into it denials because of those guidelines that are put in. Eligibility is another one. This can be eligibility of the Medicare provider or eligibility of the patient. You want to look for MA01 on the remittance advice. This is a code that lets you know that you have appeal rights. Now, for denied claims or claim lines, patient liability is determined. And one of the reasons for this is because maybe an advanced beneficiary notice of non-coverage or an ABN was given to the patient prior to the item or service being received. This is done sometimes when the provider or the supplier expects the item or service to be denied as not reasonable or necessary. So depending on how the claim was processed and what modifiers were possibly included, liability can vary. Now, what action can you take if your claim is rejected or denied? If the claim is rejected or unprocessable, you'll want to fix the claim based on the rejection you received and you want to resubmit the service. If the claim is denied, there's multiple actions to choose from. Sometimes you can fix the error and resubmit the service. You might be able to use the clerical error reopening or CER process to have the denied services adjudicated. You might choose to request an appeal. If you plan to request a reopening or an appeal, the WPS portal is the fastest and most efficient way to perform these actions. I personally hold monthly webinars on actions that can be performed using our secure portal. So if you need more information, there are recordings available on our Encore presentations webpage as well as our YouTube channel. So next, let's take a look at the data. So everything that we gathered to get this presentation ready for you today. Now, CMS requires MACs to utilize data to determine our education strategy. Our data specialists have created a dashboard, so those of us in provider outreach and education, we can analyze claim submission, rejections, and denials in order to determine educational needs. Just as advertised, today's webinar reveals the most common reasons why WPS rejects or denies Part B claims for clinical social workers, those that are assigned a 2-digit specialty code of 80 when they successfully enrolled in Medicare. Now, specialty codes are self-designated during the Medicare enrollment process. Some are not. Some providers choose to report a secondary or tertiary specialty. However, only the primary specialty code is used during initial claim processing. This slide lists the data slicers or the filters that I use to pull rejections and denial data for all clinical social workers in our claim processing jurisdictions of J5 and J8. So what this means is Part B claims, so those that are submitted on a CMS 1500 claim form or an 837P for the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. The dashboard provides 3 months of claim submission dates at one time. Each month, the data analysis loads a new month and then it will remove the oldest month of data. So that said, the claim submission data that I am presenting are for December 1st of 2025 through February 28th of 2026. The data was last refreshed on March 12th of 2026. You may be asking, like, why isn't something more recent? And part of that is because we have to gather all of this data and we have to get our presentations ready ahead of time. So it's hard to try to get all of that coordinated. So the last refreshed date that we have is that 3/12/26, and that gives us enough time to get everything prepared for you. I chose to view rejections and denials for all codes submitted by Specialty 80 providers. So Specialty 80 is the specialty code assigned to clinical social workers. Now this picture on the right shows you what the dashboard looks like. So along the top, you can see different filters that we can apply to the data being shown. First, we have jurisdictions, so we could focus on J5 versus J8 if we chose to. Next, we have part, and what that means is, do we want to look at Part A data? Do we want to look at Part B data? Or do we just want to look at everything? So if we choose Part A, that's going to pull claim information from the Fiscal Intermediary Standard System, which is also called FIS. If we select Part B, then the dashboard is going to display data that has been pulled from the Multi-Carrier System, or MCS. The claim status allows us to select denied, rejected, return to provider, or unprocessable. So we can also narrow our information down to how it processed. Next is the claim type or specialty, and this is where we can put in the specialty type 80 to make all of those results being shown specific to clinical social workers. As we move to the right, results can be narrowed down to state and even county. This could be helpful if we're preparing a presentation and we want information that is specific to one provider. Sometimes WPS does partner events, so that's where that would kind of come into play. And finally, we can look at specific HCPCS or CPT codes along with specific denial codes. Now let's get into the data with the top reasons for rejections. Remember, these are edits that occur on the front end and usually result in an unprocessable claim. The most common rejections were incomplete, invalid plan information for other insurance. This means that you let us know that the patient had another plan or insurer, but the required information wasn't provided. Next, we have rendering physician number is invalid or missing. That one's pretty straightforward. The rendering physician number wasn't valid or it was missing from the claim. Field 11 of the claim must be completed. So on the CMS 1500, Field 11 is used to provide information regarding the primary insurance plan. Now, if the answer is no, if the patient doesn't have a primary insurance plan, then you would need to put the word none there. This field cannot be left blank or else your claim will be rejected. Number 4 is treatment rendered in inappropriate or invalid place of service. This means that the service is being billed as being provided at a location that is not recognized as appropriate. So this means you're going to want to check that, see what that 2-digit place of service code was that was put on the claim. Missing, invalid, incomplete billing provider primary identifier comes in at number 5. This means that the MPI or the tax ID number is either missing, inactive, or invalid. Lastly, we have claim must be billed to RRB, and that stands for Railroad Retirement Board. So individuals who worked for the railroad and their spouses, they have their Medicare benefits administered by the Railroad Retirement Board. It provides the same coverage as original Medicare, but there are some features that are a little different. So claims for these beneficiaries need to be submitted to Palmetto GBA. They act as the contractor for Railroad Retirement Beneficiary Part B claims. Now, along with the top denials, I also wanted to show you the top codes that are rejected. The top rejected code is 90837. This is the code for individual psychotherapy focused on diagnosing and treating mental health disorders. 90834 is also for individual therapy, but it focuses on insight-oriented behavior modifying or supportive therapy. 90832 is for individual psychotherapy lasting 30 minutes. CPT 90853 is for group therapy for individuals who are not family members and have similar mental health issues. The last code, 90785, is an add-on code which represents psychiatric services where interactive complexity is needed. Give me one moment here. Thank you.
Yeah, Karen, if I can just jump in right for a minute.
Of
You're
course.
going to notice, you'll notice when you look at these codes that there's multiple codes on this slide that do represent individual psychotherapy. The main difference there, of course, is the amount of time spent delivering that service to the patient. Back to you, Karen.
Thank you, Mary. So now we can break these down further by looking at in the individual codes, and that's where we looked at those splicers where we can focus on the individual HCPCS or CPT code, and it's going to give us the top reasons for why that particular service was rejected. So for the 90837, we have a lot of the same rejections that were listed on that top rejection slide. So insurance information, rendering physician number, and that additional insurance field that can't be left blank. The 90834, again, we have the incomplete invalid plan information, the rendering physician number again, and then issues with the billing provider primary identifier. Now here you'll notice on the 90832, we have treatment rendered in inappropriate or invalid place of service. So this is when you're going to want to take a second look at those place of service codes that were used. And you're going to want to make sure that that's correct. The I'm sorry, 90853 has a couple reason codes for rejections that we haven't taken a look at yet. Rendering physician number invalid or missing means that we can't identify the physician who performed the services. This could be due to an MPI that was entered incorrectly or that was left off the claim. Missing, incomplete, invalid charges means that there's billing data that is either missing or it's invalid. Invalid or missing modifier means that the services that were billed required a modifier and it was either missing from the claim or the incorrect modifier was used. The 90785 has forwarded to Palmetto because the beneficiary was a retired railroad employee or their spouse. MACs can forward claim information to the correct MAC when we know where it should go. But I would still follow up with Palmetto and check claim status, make sure it's over there, see what's going on, things like that. Um, Patient insured MBI and name do not match. And you're always going to want to make sure when you're submitting your claims that you're using the name exactly as it is shown on that patient's Medicare card. So even if your office knows the patient is Kenny and everybody calls him Kenny, if his Medicare card says that his name is Kenneth, then you're going to want to make sure to submit your claim using the name Kenneth. Top reasons for denials in descending order. So now we're going to switch gears and we're going to look at the top reasons for denials. Collection of fee for service during periods of managed care. Here, the patient has a Medicare Advantage or a Part C plan. So original Medicare should not have been billed for the service. Not covered when preferred, referred, or ordered by this provider comes in at number 2. This means that the performing, referring, or ordering provider is ineligible or not authorized to order the specific services. Maybe they aren't enrolled in PACOS, or maybe their MPI was invalid or missing from the claim. Duplicate charge paid date on claim ICN. Now, for this denial, the system is going to provide the date and the claim number where the services were originally paid. So that information will be filled in and you'll be able to tell which that duplicate claim was. Physician or supplier is not eligible to receive payments. This typically means that the provider is not enrolled or has opted out of the Medicare program. Duplicate charge of claim ICN now being processed. So here's another duplicate claim denial and the system is going to provide you with that ICN number. Medicare will not pay for this service for this condition. This usually means that Medicare has determined that the service is not medically necessary or it is not covered for the diagnosis that was reported on the claim. This is usually an appealable decision. Last on the list is the time limit for filing your claim has expired, no appeal rights. Providers have 12 months from the date the services were provided to submit the charges to Medicare. Although this is not appealable, our appeals department receives numerous requests to have this decision overturned. If you would like more information about timely filing and what is considered good cause for requesting a waiver, there are encore presentations available on our YouTube channel related to this topic. So here we have the list of the top codes that receive denials. We have the 90837, 90832, 90834, and the 90853. Those were also included in that top rejection list. The new one here is the 90791. This is for psychiatric diagnostic evaluation without medical services. And this is typically reported during that initial session when the patient's history is taken and a diagnostic assessment is performed. Now here we see the top denials for code 90837 and 90832. The majority of these are what we saw on that top reason for denials that we looked at when we were discussing the top denial reasons. Deny hospice service when provided by a non-attending physician is one that was not covered earlier. This occurs when a patient is enrolled in hospice and a claim is received from a non-attending physician. Services related to the terminal illness would not be covered by Medicare. If these services are unrelated, then there are modifiers that could be added to the claim. (90834) and 90791 also have top denials that we've already discussed. I do want to talk about the top denial for 90791. Medicare does not pay for this many services in this time period. So typically a psychiatric diagnostic evaluation is considered for payment once per patient, per provider, per year. Now, this isn't to say it can never be performed more than once a year, but if it is, it should be because there's a significant change in the patient's condition. So that's something that you would want to have documented in their medical records. Now here we see a couple of new denials. Missing, incomplete, invalid place of service for this procedure means that the place of service code was missing from the claim, it didn't match where the services were provided, or it's invalid. Provider not eligible or certified for this procedure, for this date of service, is pretty self-explanatory. It means that the provider is not eligible or certified to be paid for the service that was provided and billed on the claim. So now that we've covered the reasons for the top rejections and the top denials, let's take a look at ways to fix or avoid these situations. Now, CMS has provided some guidance in their internet-only manuals. The Medicare Claims Processing Manual provides a lot of guidance that will help you with billing requirements. A lot of those sections even break down topics to like this is what should be included on a Part A bill and this is what should be included on a Part B bill. So there really is a lot of information out there. There are certain chapters that focus on submitting claims and getting the required information on there. So Chapter 24 focuses specifically on electronic billing. So this is going to refer to like the 837I or the 837P transmissions. Chapter 25 provides information for the CMS 1450. These are Part A claims. This is also referred to as the UBO4. So this is for Part A providers who submit claims in FIS. Chapter 26 is going to cover the CMS 1500 form. So that's going to be the Part B services, the claims that are submitted through the multi-carrier system. Now the link included here in the title is going to take you to a crosswalk for fields on the CMS 1500, and it's going to show you how it transfers to the 837 file. Now this is really nice because it takes you through each loop found on that 837 file. If you're anyone who has looked at these files, it can get really confusing with all of the data that's on there. So this is really nice because it gives you that loop so you can kind of find that on the file and find the information that's in there. What I also like about this resource is that under the status, it gives you an R or an S. So it tells you if that data is required or if it's situational. So that can really help to make sure that you get your submissions correctly and that we get the data that we need. Now here you're going to find a link to the review contractor directory. This is an interactive map that is going to help you determine where you need to submit your claim. I'm going to click on this really quick so we can go out and take a look. So I'm just going to click on Nebraska because that's where I'm physically located. But this is going to show you where you need to send claims depending on the type. So you have the AB MAC, you have durable medical equipment, home health and hospice, the Railroad Retirement Board, Indian Health Services. It has the Recovery Audit Contractors or RACs, and then it also has the Unified Program Integrity Contractors or UPICs. So if you have a question, maybe you normally bill us, but then you have a situation that comes up and you realize it's a Railroad Retirement Board, and you're like, where do I send this to? This map can help you with that information. Now, we discussed that some of the rejections and the denials regarding whether or not the provider was eligible to bill Medicare. To avoid these issues, you want to make sure that the provider identifiers are reported on the claim when required and that they are reported correctly. This is going to include the rendering, the ordering, or the referring physician. Make sure you're aware of the eligibility dates within your provider eligibility record. That way you're not billing outside of those dates. The resource on this slide is very helpful in determining if a physician or a non-physician practitioner is legally eligible to order and refer in the Medicare program. I do want to go out here because I've found this a very nice resource. So here you can search for physicians and non-physician practitioners. If you know their MPI, you can search by their MPI. If you don't know that, you can search by their name. But you can see over here, it gives you a little yes or no, and it has it broken down into Part B, DME, home health. The PMD, that refers to power mobility devices. So um, that would be referring or writing referrals for getting a power mobile device. Sorry about that. We also have hospice. So I just wanted to show you, I thought that was a great resource just because if you don't know the provider or the physician's MPI, you can still look them up. Patient eligibility denials and rejections. Verify the patient name and the MBR are an exact match. We talked about that earlier. A lot of people go by nicknames, but you want to make sure that you're billing with the same name that's included on that Medicare card that they got issued. Check to see if the patient's enrolled in a hospice. That way you know where you should be submitting that claim to. Also, you know, submit it to the correct payer. If it's supposed to go to the Railroad Retirement Board or if they're part of a Medicare Advantage plan program, those are different contractors. We don't process those claims. And I know that we get a lot of questions about Medicare Advantage plans, but those actually go through private insurance companies, so that's not something we handle here at WPS. Modifier issues. Make sure that if a required modifier should be on the claim, make sure it's present. Um, does the modifier match the procedure code that you have billing? Is it valid for the data service being used on the claim? All of those things you'll want to check. Now, Medicare does not make Part B payments under clinical social worker benefit categories for some services. So here I have a list of services that Medicare would not provide payment for. I also have a link here to the place of service code set. So here you're going to find a place of service codes in their descriptions, just in case, you know, there's a lot to keep track of. So there's another place that you have for reference. Avoiding duplicate claims. I know there seems to be a lot of stuff with AI, and I know a lot of providers and facilities are trying to get AI incorporated into their processes so it kind of saves time. But a lot of times these AI processes will auto resubmit claims when you don't really know what the status is. So that can lead to an increase in duplicate claim rejections. Sometimes this can be viewed as abuse of the system because they're constantly resubmitting claims, which is causing more work and it's unnecessary. You also just want to make sure that you aren't billing us for charges that have already been billed, or make sure you have appropriate modifiers if it is a repeat service. Now, we do have a couple options available for checking claim status. We have the IVR system, that is an automated system that you can go through, but we also have the SecureNet access portal that we just refer to as the portal, and that also has claim status available there and will give you information even on denials and rejections. Now, if you have questions on coverage or frequency, things like that, WPS does have a local determination policy, or LCD for psychiatric and psychological services. It also has a companion guide that will provide you with billing and coding guidelines. Mary has covered these. Actually, Mary had a whole webinar that just talked about the LCD and the companion article. So you can find a lot of information there. It gives you codes that should be used. You can find, a lot of times you can find documentation requirements, things like that. So those are also really good resources if you have questions about the coverage or the frequency of the services you're providing. Timely filing denials, I mentioned earlier, that's something that is high across the board. We do have a resource out on our website. Timely filing denials are something that cannot be appealed and they cannot be rebilled. So you can't just resubmit the claim in the system. You have to take a paper copy of the claim. You have to have a reason of why we should um, why you missed that timely filing deadline, and that gets sent into our claims manager. So we do have a resource out here. Of course, you will want to make sure that you are in the correct jurisdiction up here, um, because of course for J5 and J8 we're going to have different addresses. So that's something to look at if you have a claim that's denied for timely filing. Another thing that comes up a lot with timely filing is MSP, where another insurance has paid for the claim. And so you're like, well, I'm not going to bill Medicare because their primary insurance paid. And then a couple years later, the insurance comes back and takes their money. So even if another insurer paid, still submit that claim to Medicare and report that primary insurance information. So that way, when they come back, if they take their money back, you're not stuck in a situation where you're not getting paid for those services. Managed care plan, we do see a lot of claims that should be billed to a Medicare Advantage or an HMO plan, and they get billed to us, so they get denied. So here's some information on that to make sure, just check to see do they have a managed care plan? If they do, who is that through, and who should that claim be submitted to? Billing for services during a hospice election. So there's some information here. Um, Depending on whether the services are related to their terminal illness or not can affect how you bill. So you'll just want to make sure to check that information before submitting a claim. So things can get even more complicated when you have a patient who's eligible for Medicare, but they're enrolled in a Medicare Advantage plan and they also elect hospice. So this is another WPS resource that provides some guidance as well as some CMS internet only information if you happen to have a patient that meets that criteria. So I know I just showed you some resources. We have a couple more that we're going to go over. And we really just want to provide you with the most information that we can to help you get your claims paid. If you have a rejected claim, we do have a resource out there that tells you how to correct a rejected claim. Depending on the rejection that you received, it'll kind of walk you through like what you can do to fix that problem. We also have a rejections and a denial YouTube playlist, so you can go out there and find information on the specific rejection or denial that you have. For patient eligibility, we have the portal that you can use. That provides a ton of information. You can actually go out there if you don't have a patient's Medicare number, but you have their name and date of birth. You can go out there and the system will provide you with their Medicare number so that you can check eligibility. There's a whole list of things that you can find as far as hospice, Medicare Advantage, MSP information, all the preventive services so you know like if you should be billing, if there's going to be a frequency problem. Um, Also the Medicare Learning Network, CMS, their Medicare Learning Network I really like because I feel like it takes all of the CMS regulations and it kind of puts it into more user-friendly wording. So they do have a booklet or fact sheet out there for checking Medicare eligibility, and it walks you through all the different options that you have for checking the patient eligibility. Modifier help. uh, I know that I work for WPS, but I have to say that I think that our modifier information out on our webpage is really great. If we go out there and take a quick look, I do want to show you because you can access it from our home page. We have it over here in the quick links, but we have fact sheets for so many different modifiers. You can just go out here. You can look for the service or you can look for the specific modifier, but we just have tons of fact sheets out here to help you for appropriate usage, inappropriate usage. And I know I'm kind of biased, but I just think that we just have such great information on modifiers. We also have a YouTube playlist. If that's something that you're interested in, you can see the webinars we've held. Common claim denials, we have another WPS resource that where it kind of arranges the denials by category. So we mentioned that there's a lot of denials for duplicate claim or service. So you can go out there, you can look at that specific category, and it can tell you how to work your claim and how to fix it. Clerical error reopenings, if you need help with that, we have a resource for that. I also covered that information in a portal webinar on the claims functions that can be done within the portal. So there's some couple different resources for that. If you happen to submit an appeal on one of your denials, then this kind of just helps you with the flow of that. We also have held a bunch of webinars on the appeals process recently that can help you with that. The important thing to remember about that is you have to submit your appeal within 120 days from when the claim was denied or rejected. And then you also have to give WPS 60 days to make a determination on that. We get a lot of duplicate requests. Now, before we get to the question and answer session, I would like to take just a moment to talk about overpayments. WPS receives many overpayment notification and refund requests from providers, and we know that you want to repay Medicare in a timely manner. However, there can be delays if you use an incorrect or outdated form. Missing information or sending checks without explanation are another reason that can cause delay. So to avoid unnecessary holdups, please consider using the portal for refunds or overpayment claim adjustment features. This allows you to do it really fast and efficiently. Now, there are times that you won't be able to use the portal, or maybe you don't want to use the portal, so instead you may choose to send paper requests and checks. If so, we recommend using the correct form available on our website. Now, I do have a couple pre-submitted questions that I want to get to before I ask Mary if anything has come through in the chat. So the first question I got is, are there diagnosis restrictions with code 90832? Yes, there is. The WPS companion article, known as the billing and coding article, does list covered diagnosis for the CPT codes. That was something that was provided, the link was provided in the slide where we went over the LCDs in the billing and companion article. That is article A57480. Next, we have, are services of clinical social workers separately billable on CMS 1500 form when performed in a partial hospitalization place of service? The answer to that one is no. Medicare covers clinical social worker services when rendered in a partial hospitalization program, provided that the services are part of an active treatment plan, that they're reasonable and necessary, and that the provider is Medicare certified. However, these services are generally billed by the hospital or the community mental health center as part of a bundled PHP service. So it's not billed on that 1500 claim form. So in other words, it's normally included in that Part A bill that comes in. Next question is, how does the AJ modifier affect the reimbursement for both outpatient services and in a PHP? So for Medicare purposes, the AJ modifier is considered an informational modifier and not a payment modifier. Other payers may require it and consider it a payment modifier when it comes to services submitted on a CMS 1500 form that are processed for clinical social workers services. Medicare Part B approves payment for covered services at 75% of the physician fee schedule. In a partial hospitalization program, services are part of the bundled services, and the Part A payment is made to the facility. The next question is, how are we submitting claims when patient chooses us over their PIHP provider? So PIHP is Prepaid Inpatient Health Plan, and that is a managed care entity that provides specific services such as inpatient hospital or behavioral health care under a contract with state Medicaid agency. It's often operating as a capitated payment basis without a comprehensive risk contract. So WPS processes only traditional original Medicare enrolled beneficiary claims. So I would recommend contacting Medicaid when it comes to that question. Next question is, if I had to give our social worker and billing staff one piece of advice to avoid rejections and denials, what would it be? So to avoid rejections, use the claim form instructions and be certain that you report all required information on the claim. To avoid denials, the best advice I have is to refer to the LCD and the billing and coding guidelines to understand what WPS considers as medically necessary and reasonable. The last pre-submitted question, and unfortunately this is probably all that we will have time for, so any questions that came through in the chat, if Mary has not answered them, then I will compile them and I will send an email out to everybody in attendance and we will get those answers to you. The last question I can cover today is there a requirement for how often treatment plans need to be updated or reviewed? No, generally speaking, Medicare would expect updates at a frequency that documents the ongoing medical necessity for Part B outpatient services. Keeping in mind that some intensive programs like partial hospitalization program services have strict requirements. So you'll want to update plans to show when goals are met, when adjustments or when frequency of the sessions has changed. Document that the patient is making progress or what the treatment continues to be needed or to prevent things from worsening. If goals are not met, document why and what adjustments are being made. And again, you can always refer to documentation guidelines in that WPS LCD that we gave you that link to.
Karen, I just wanted to mention really quick here, you said if we didn't get to any of the questions in the chat or get to all of them in the chat that we would share answers later, but we have gotten to all of the questions in the chat. So I was able to respond to just a couple of questions we had. They were great questions. And if you have any questions that you didn't think of during today's presentation, Karen's going to tell you in just a minute how you can submit those to us. Back to you, Karen.
Thank you so much, Mary. Thank you for handling all those questions that came in. We really want to make sure that everybody gets the answers that they need. Now, when you disconnect from the webinar, you are going to be redirected to a CMS survey. I'm also having Mary add a link in the chat. I really do hope that you'll take a moment to provide feedback on how I did today. If you're watching this video as an encore, you're going to see a pop-up at the end of the webinar with a picture that says survey. Now, the redirect is going to look like what you see here on the right. We don't have any control over how this appears, so we just want you to know it's not spam, it's nothing malicious. In our encore videos, the survey link is going to look like that picture at the bottom. Now, the feedback that we received does lead us to changes. We've added chapters to our encore presentations. We've added training indicators to the description of our webinars to help provide some additional guidance as to whether the webinar may apply to you. We've also held 2 Medicare Education Expos based on suggestions for future education topics. We're currently planning a 3rd one that's going to be held later this year, so watch for details for that to come out soon. So as you can see, your opinion really does matter. Now, after disconnecting today, you will receive a thank you for attending email that's going to contain contact hours that can be submitted for continuing education units. If you joined only by phone, WebEx is not going to be able to generate this email, so we will need you to contact us. In the chat, Mary will add a link to the education mailbox and what information is needed for us to send you a certificate. Now, if you think of any questions, those can be submitted for up to 7 days following the event. So just get those into the education mailbox and we'll get those answered for you. This brings us to the end of today's presentation. On behalf of myself, Mary, and the Provider Outreach and Education team, I would like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.